So, I thought to invite, so I'll just step back for a second. So, I work for you. I work for the taxpayers. I'm public servant under Health and Human Services. So I report to Benita McLaren, who's the director of Department of Health and Human Services, who reports to the Board of Supervisors. Our shop at Health and Human Services is the biggest department in the county. It's about 700 people total, mainly divided into three branches. There's mental health, behavioral health and recovery services is the current term, then public health and social services. And then we have now a new division around homelessness, with much smaller, and then sort of administration. So, most of the topics that you raise are really mostly held by Todd Shermer, who's the new director of behavioral health and recovery services. We obviously have a lot of overlap, and I'll be addressing those areas of overlap where they overlap with public health per se. And I think in some ways they can be framed as public health issues themselves, although they are the spectrum of mental health and well-being. And in Todd not being here, I don't want to talk too much about the programs themselves, because I don't know exactly, how. Todd you should invite Todd to have that.
Yeah, we will certainly do that. We had him for the panel on care courts, of course.
Yeah.
And we've had him before, and we'll have him again soon.
Yeah, but I have a strong, I think I have a strong sense of the, where the overdose, the substance use side of it, and how because that is, I had sort of raised that as a public health issue, primarily in 2014, 2015 in Marin County, where we were seeing opioid overdoses, and that strategy has evolved. So that was framed as a public health issue at that time. And maybe, so we can talk about OD, what is now OD Free Marin, had been RX Safe Marin, which is our community coalition to address that issue. And then I also would love to talk about this issue of burnout that you brought up, and sort of the healthcare infrastructure across the board, and my observations about what we're seeing now and what some of the remedies might be for some of that. And suicide as well, our plan. So let me just jump into the overdose stuff. I'll give you just kind of a sense of the background. The overdose crisis in the United States has at least what I think of as, or CDC also describes as three kind of main waves. The first wave was opioid overdoses fueled by prescription opioids. And if you watch like Dope Sick or any of that, really starting in 1995, Big Pharma, Purdue, telling providers that they need to treat pain with these quote unquote, safe and effective and non-addictive medicines like Percocet and OxyContin, and those. Obviously, that turned out to be untrue, and I am among the physicians that was probably, frankly, misled by pharma into overprescribing opioids for pain, to the detriment of our patients, many of whom were rendered addicted through our own practices. That's now led to a settlement where there was actually a lawsuit against virtually almost every piece of the system, whether it was the pharmaceutical companies, the manufacturers, the distributors, the pharmacies that were dispensing them. And so too little, too late, but we are now the beneficiaries of some funding for our current strategies based on a settlement that it was, just the first piece of the settlement came through just a few months ago, $800,000 a year in Marin County for the next 9 years, and that's from McKesson, which is one of the distributors, and Johnson & Johnson. And then we have another set of settlement dollars that will be forthcoming at some point, probably later in the year, from CVS, Walgreens, Walmart, and some of the other pharmacies. And then there's another set of distributors that are in litigation right now. So the good news around that first wave is that there's accountability to the pharmaceutical industry, and it's funding some of our strategies now. Our opioid prescribing, we started RX Safe Marin, which is the coalition, in 2014. The reason it was mainly public health was that a lot of it had to do with healthcare providers themselves. And I, was working with the hospitals, with the clinics, really trying to find safe and effective ways to manage pain that were not by using opioids. And we did a lot of good work to reduce opioid prescribing. And I think we're one of the earlier counties to sort of recognize this as such, as a problem, and to sort of counter what even at that time the pharmaceutical industry was still claiming were safe and effective remedies. 300% reduction in opioid prescribing in Marin County in the last over 6 years, from 2014 through 2020. And I think we're kind of in a good place in terms of just a balance point where it's being used judiciously for the people who need it, especially palliative care, end of life, all that stuff, but not being overprescribed. But unfortunately, it's, the issue got more complex. The second wave of the opioid epidemic, it was heroin, starting around 2015. We were not as deeply impacted in Marin as other counties with that, but you can see appreciable increase despite seeing decreases in prescribing, in mortality. The most important piece was wave 3 for us, which is fentanyl, starting in 2018. And we've seen an ever increasing number of overdoses in Marin County fueled by fentanyl since 2018, tripling since 2018, doubling in the last 3 years. And we're up to, 1 death every 5 days in Marin County from an overdose. And we have two overdoses a day, 2 non-fatal overdoses per day in Marin. If we look at our EMS data, ambulance data, it's affecting every community. Those ambulances are traveling to the hills of Ross and Tiburon and the canal and downtown Centerville. And it really is, maybe the determinants differ in different communities, but the impact is experience in every community and in every age group. When you break it down by age, you really see, the most impacted age group is actually our middle-aged residents in terms of overdose deaths. But so it is a complex problem. When we talk about our education campaigns, the first thing that our media folks want to know is, who's your target? Like, who are you targeting with this? And I am always saying everybody. We really need to find a way to reach everyone. The messages might differ depending on the demographic group we're trying to reach, but every single resident needs to be getting the message around the risk. So that this current strategy is primarily threefold. Under OD Free Marin, which is the community-based coalition, using a collective impact model to bring together all the sectors that are necessary to touch us: our healthcare partners, our law enforcement partners, our schools, our clinics, public health, mental health. And those are education and awareness, Narcan, which is the medicine that can reverse the effects of an overdose, and treatment, access to treatment and recovery services, navigating people who are suffering from substance use disorder or opioid addiction, navigating them to the services that they need and deserve. And that's probably, as I come out of COVID, is the thing that I'm spending most of my time on now, is reinvigorating what had been RX Safe Marin, our community coalition, into OD Free Marin. That change in the name obviously was important because it's not prescription anymore, RX being prescription, and also an invitation to sort of broaden the coalition, to go beyond the prescribers and the pharmacists that were so important for that first wave, to be more comprehensive, especially for our schools. So we have a lot of engagement with the Marin County Office of Education and other partners who touch youth in this. And we've got just to highlight some of the key strategies. Narcan, the nasal spray that can reverse an overdose, is available now in every single high school and middle school in Marin County through the coalition. Just a great example of what kind of a community-wide coalition can do, is to have that kind of penetration across the county. Developing curriculum, we're now working on trying to develop, address, I would frame it as the problem statement is that not every school has the same capacity and bandwidth to offer the teaching and education to the students. And that's inequitably experienced. So schools like, Novato or Santa Fe cities where there's just, there's more challenges, and it's really hard to just load onto the shoulders of those teachers like yet another thing to have to teach around. And so we're working on getting just an evidence-based, really good 3-day curriculum into the middle schools that would be available for every single middle school in Marin County, public middle school, so that we know that every student at the middle school level, 7th grade, has the same basic foundation of understanding moving forward to sort of address those inequities and have them obviously be culturally relevant and linguistically appropriate. And that's a partnership between OD Free Marin and Marin County Office of Education. And then we're also partnering with Independent Journal for what will become a campaign, 2 ads a week or two pieces a week going for the next year. So people are aware. I think one of the biggest gaps there is just the fact that people don't necessarily know that the drug supply has essentially been poisoned with fentanyl. And so what might have been more normative sort of experimentation for adolescents or any age is now potentially fatal. There was a party of some women in their 40s. One of them was having a birthday party, and someone brought some cocaine, I guess, to sort of, it wasn't like a really majorly substance using group, but there was obviously a little on the wild side, and they decided that, and it was laced with fentanyl, and they were unaware of that, and 2 of them passed. So it's not just young people, it's really just, so it's a message for everyone that one pill can kill. So there's lots of pieces to the education awareness campaign. And then Narcan, as I mentioned, we're getting that to all the schools. And our goal is to see Narcan as the way we see AEDs or other, it really should be no more than a couple minutes away from anyone who might be the victim of an opioid overdose. Because it's, opioids suppress breathing. Fentanyl suppresses breathing. That's why it's fatal. Because you stop, you have 3 or 4 minutes after you stop breathing before you're not going to be revivable. So we really need to make sure that Narcan is available at hand, especially in situations where the risk for an overdose is higher. And there's a lot of strategies therein. And then I think the most important and probably most challenging area is the treatment. We see a massive treatment gap, and I think this is probably for the League of Women Voters just something that may have some sort of legislative correlates to it, which is we just need better infrastructure for treating, finding opportunities for people who are addicted to get treatment for addiction. We have, Marin, the way Marin, our Health and Human Services, Todd's shop, Behavioral Health Recovery Services, is really statutorily responsible for our lower income residents who are on Medi-Cal. And there's almost this irony or paradox that some of our lower income residents are actually therefore eligible to access services that if you're middle class, you may not have access to. So there's a huge treatment gap in Marin and everywhere in the nation, especially as the opioid crisis accelerates and more people need that kind of support. The fact that the supply of those supports has been static or even diminishing has become it means the gap is wider and wider. And those individuals who are addicted, who are not in treatment, day by day are just accruing risk of death, of overdose, because they're continuing to use. So I think that's another important priority for us. That's what we're spending our $800,000 on, that we're getting from the from the opioid settlement is really going to go primarily, into like 700 of that 800 is going into just substance use treatment, navigation. So when someone hits an emergency department who's had an overdose, instead of just being stabilized and released, there's dialogue, there's there's a conversation with that individual and their family, their support, their loved ones, to say, okay, how can we make sure they have Narcan available, that they're tied into services if they're willing to get services now? How can we do a follow-up call, even a visit to the house? I mean, just there's a whole, the level of care and support people who are at that high risk need is categorically higher than what the current system allows for. And so we're trying to fix that. So that $800,000 goes like nothing when you're talking about individuals, right? Because that's like 4 people, like that's like 4 staff members to like, and if the treatment gap is, if there's 1,000 people out there who are not accessing treatment, who would otherwise, that 4 individuals isn't gonna solve their problem. But it is probably our highest yield investment still at this point.
Do you have any ability to train more professionals?
Yeah, I mean, I think there's a need for sort of recognizing the spectrum, like, and working across the spectrum. So that at one end of the spectrum, you have like psychiatrists and like addiction specialists who are super expensive and can only see a few patients really at the end of the day. So there's different models now to sort of optimize or make more efficient the workforce. And the Sun's substance use navigators, peer counselors, that's kind of where I think the money or the highest yield would be, is getting people who can kind of serve at least 20 to 30 people kind of within their panel that they're managing. And there are opportunities to increase that. So that's part of what we're doing with that opioid settlement funding, is building out that network of lower level professionals who can support people through counseling or it's literally, they're called substance use navigators. And if anyone's tried to sort of find their way through the system, they all understand how important navigation itself is. Any questions on so that's the mental health, I guess that's, and I maybe just to correlate back to the pandemic, it's been sort of a perfect storm, right? Because the pandemic has caused such a profound kind of disruption of people's just mental health and well-being and social connectedness and all that stuff that is really the antidote to addiction in so many ways, combined with increased availability and supply of these particularly lethal substances like fentanyl and xylazine, which is called tranq, which is also coming onto the scene. So we're battling kind of, and then the third piece of the perfect storm is that the healthcare infrastructure that's designed to help is also on the ropes, with burnout among the providers.
Yeah. John,
Yeah,
go ahead.
Yeah, Dr. Willis, I'm just wondering, how exactly are these medicines getting laced with fentanyl? I mean, what's the route and how do they do it?
Yeah. So fentanyl is, you'll hear that fentanyl is a prescription medicine, and it is. Historically its manufactured, was used by anesthesiologists. They're patches. There's ways that fentanyl has been used. 95% of the fentanyl that's being used right now is non-prescription. So it's the global supply seems to sort of the dominant pathway seems to be some of the building blocks and substrate being manufactured in China, moving to Mexico, being funnelized, and then put into powder form, which is highly lethal. I mean, just a small amount, like a few grains, can really be enough, depending on, especially if someone is naive, to be enough to cause an overdose. So it's extremely easy from from moving around, it can be transported very easily across the border because it's a powder. It can be put into almost anything. So it's very easily smuggled.
Yeah.
And so it's being added to. I mean, there's they'll put it in dolls. There's all these different. The DEA has all sorts of examples of creative ways that it's being brought in. And then it's being distributed. Locally through channels. It's I think one of the most sort of dangerous forms is the pills. So that Xanax, which is a benzodiazepine that is a commonly used sedative that is available for purchase online, is now almost all contaminated with fentanyl. Adderall, when people buy, Addies online, fentanyl contaminated. As I understand it, the drive to contaminate products with fentanyl from the marketing standpoint is that it renders people addicted very quickly because it's very powerful. So it moves from sort of an accidental exposure and hopefully non-lethal exposure to an experience where someone will actually seek that product in the future. So it's actually because it doesn't make sense for people to intentionally kill their clients. So there is a motivation to add fentanyl to the drug supply, because when people are seeking, the dopamine release, all that is enhanced by fentanyl, and it renders people addicted very easily.
So are some of the pharmacies actually doing it? I mean, getting it?
No, it's all. I mean, like it's in it's like methamphetamine. They have laboratories and and their basements and garages and that kind of stuff. And you can buy online. You can buy pill. Like something that will actually make pills, and they just develop a paste that will be a combination of substances, including fentanyl. Then have the pill presses make the pills in a way that appears to be a product that is well known, like Xanax or Adderall, and then distributed on the black market. And it gets into Marin. I mean, we see this even in our own county.
So this wouldn't be Adderall that people get from a pharmacy. It would be something they get from a friend or something.
That's right. And so one of the most key messages is, like, if you're taking a prescription medicine, it has to be a prescription medicine. It has to be one of your, like, something that your own doctor prescribed, that you picked it up at the pharmacy and it's being taken for a therapeutic reason. Prescription drug abuse has been a big issue, right? And by definition, that's people taking prescribed medicines that are not prescribed for them, and they know exactly where it's sold on the street or exchanged at parties or whatever. That's the supply chain right now that is most concerning for our young people, because that was normative, especially in Marin. These pill parties, they used to talk about like a bowl of pills, and people would walk in and just take one to sort of see what the effect was. I think some of that is a little urban mythy. I don't know how often that actually happened, but that idea of taking prescription medicines that were not prescribed for you as part of kind of the recreational drug experience in Marin County is something we're working very hard to change, because it's now much more dangerous.
Dangerous.
Go ahead, Dee.
Dee?
Hi, Dr. Willis. My question relates to Narcan. I've entertained the idea of carrying it on my person. Let's say as Mary Q. Public, I'm walking down the street and I witnessed, actually this happened, I was in San Francisco and I witnessed an overdose across the street. What's my legal liability if I were to get involved and administer the Narcan myself?
Yeah, that's a great question. And that comes up frequently. So there are, Samaritan laws that first of all, Narcan itself is highly safe. Like, you're not going to hurt someone with Narcan, right? So right off the bat, the likelihood that there will be sort of an adverse outcome related to that effort is very, very low. And the likelihood that there's a very favorable outcome is very, very high. But even if there is something, there are Samaritan laws that protect people against liability for that. It's like CPR.
Thank you.
Do you want to just touch on the that was the opioid stuff, and I'm running out of time.
Yeah.
Is there another topic that
I
you'd
think
like to?
that was a huge one. Linda, do you have a question in regard to, we've sort of touched on the younger a bit, but we haven't touched on the aging part of our population.
Yeah, you get about 30,000 young people and 77,000 old people. So, but Matthew knows this topic very well. But yeah, I was hoping, I'm sorry I was late, but I'm not. Love to hear what's happening in HHS, Matthew, for.
Yeah. Hi,
Yeah.
Linda. It's been a while. Yeah, I think we're looking at life expectancy. So Marin County was just ranked, the healthiest county again, longest life expectancy of a lot of counties. The way I think about longevity, and where we're trying to sort of shift the thinking in the county, is that it is a lifelong. You set the stage for living long and living well at every stage of life. Right now we know that the leading cause of premature preventable death in Marin County is cardiovascular. African American residents are twice as likely to die from heart attack and stroke as their white counterparts before the age of 75. So there's a lot of work right there to, I think, address the inequities around life expectancy in Marin. In terms of I would say the outcome of that success is that we have a lot more older residents, and that's part of, as Linda's involved in the Aging Action Initiative. There's a lot of work there. I think we need to, and I know that there's been some conversations about that I haven't been all that close to, frankly, about where that's configured, like how that's configured within Marin County government in terms of where do we place aging, whether it's its own division, whether it's its own department, how that works. I think one important step is to first do kind of a clear inventory. One of the problems is that we have is this sort of the silo issue, right? So we've got aging is named per se as one team, right? But obviously it's actually cross-sectional across all of the teams, right? There's an aging correlate to mental health. There's an aging correlate to public health. There's an aging correlate to homelessness, so all of and I think what we need to do is kind of flesh out the whole rather than expect Lee Pullen and his little shop to sort of be the be all and end all around older residents. It doesn't make any sense. And so I think we've probably not complete, to my mind, because I know a lot about what we did around our aging population for the COVID-19 pandemic, which had nothing to do with the aging team per se. It was a public health, and like the work we did with our long-term care facilities, I would say, 25% of our COVID energy, the time and resources we put in, were really dedicated just to that one setting because it was where our greatest risk was and our greatest mortality rates were. And I don't know that has really fully informed the assessment of what the gaps are. So I think we need to, I think one of the first things we need to do as I sort of resurface and start to engaging in this space from a public health standpoint is to really do that full inventory of like where are in the non-aging services activities happening and how do we better organize and coordinate those things and communicate those things. So sometimes I feel frustrated that there's a narrative that things aren't happening that are happening, and it's just that's a communication issue. But I am fully, I think, aware of the need for Marin County in particular to have a clear strategy for addressing the reality of an aging population. And I see it's part of our legacy as a county is that we have I mean, I love to talk about Marin County as a laboratory for healthy living, because we are. We can't obfuscate our responsibility in that space, because if you look at Marin from anywhere else, what you see is a vibrant community where people are living well and living long and are active and have access to healthy nutrition and have access to physical activity and have access to healthcare. And and sometimes I think we get stuck in sort of the parts of the equation that don't match that. But I would love to sort of take a strength-based approach to this, and so flush out what are some of those wonderful elements that are placement that are demonstrable through evidence, through data. A life expectancy of 85 years, one of the longest in the nation. What does that mean about us, and how do we amplify those things to reach everyone? I know that's probably not answering your question at all, Linda, but
Isn't some of that we're very privileged to have clean air, clean water, access to healthcare, plenty of open space for exercise, and that's not all communities can have that. It's not, you can't just transfer that easily across the state.
yeah, but there's a lot of it is, I think that's true, but I think sometimes we're premature in saying, well, it's easy for Marin because blah, blah, blah. It's dismissed. When I think actually a lot of it is culture and practice and community, cohesiveness, community supports, people like you all who like participate, right? Who like are interested and engaged. And I don't know, I think there's a lot, because if we just say it's a Marin specific thing, then we don't really have anything to offer anyone else, right? It's like, well, nanny, you know, aren't we lucky? But I think it's a lot more than that. I see a hand.
Brian.
Thank you. What do you think of single payer healthcare? Our costs in the United States are more than twice what the other leading nations have as a cost per person for healthcare. And one of the reasons is that we're always advertising, get health insurance, get health insurance. And corporations and businesses have to provide their employees with insurance. It's very expensive for them. And of course, an insurance company can't prescribe an aspirin. They don't do healthcare. They're in business to make a profit. And their profit is made by paying out the least possible, taking in the maximum possible. And we're saying, get healthcare through an insurance company. If we get rid of this insurance company, we're getting rid of maybe 20-30% of our cost on healthcare.
Okay, Brian,
providing everybody with healthcare.
Give Matt a chance to answer.
Yeah.
Okay.
Because he has told us he needs to go, or
Yeah, and I
go.
just let them know that I'm going to be a little bit, but I am a big believer in a single payer healthcare system. I'll just say that. Like I agree with you. And I feel like every perturbation of our health sort of just demonstrates why we need a categorically different way of approaching healthcare in the United States, like COVID. I used to work in Indian Health Service. I spent 4 years in Indian Health Services on the Navajo reservation. And I was in the middle of the reservation where everyone around me was our patients. They're all getting care from through Indian Health Service. And it was a hospital and a clinic and a pharmacy and a laboratory. And we had our MRI and we had our CT scanner and our X-ray. And we had our community health programs and we had schools. And it was just one system. And I did not realize how privileged I was to work in that system, because I could see everything, and all the incentives were aligned, right? So if we prevented something from happening by building a skate park for youth, it saved money on the MRI, the CTs, whatever we have to do for the cardiovascular disease. You know, it was like, so prevention was incentivized. And we had to think about what we were spending our money on, right? Because it was our money. It was like we had a given pool and we had a given population and we had great doctors. And, you know, so our vaccine rates were some of the highest anywhere. And I don't know, it was like this example of what it can look like, where you're not having seen people fall through the cracks. It drove me crazy when I moved to Marin and started doing primary care. On the little sticker on the top of every person's chart was there included on the upper right side their insurance. And it was almost like you had to look there first before you could even begin, like whether you can even see the person. I mean, it was crazy. And then it's like, okay, well, yeah, I'm going to see them, but the tests I'm going to be able to order or are going to depend. It's talk about, I think it's one of the most important factors leading to burnout right now. Is sort of the moral injury for people who start into a vocation that is about service and they want to heal. And then they're just hammered by like rules and filters and allow and non-allowances. And by the time you get through, you're like, no, I'm done with this. Like, so, I mean, I think it's coming to maybe a boiling point where these conversations might actually be renewed around, I mean, I thank God Obamacare passed. But I don't know. I mean, I think in our team, you will find certainly champions around equity and access to healthcare, whatever that is at the moment, whatever sort of strategy seems relevant at the time or legislation seems relevant at the time. I think that's another area I think for us to be really working together around, because there's no, I mean, that's like an easy one. When it comes to health and equity, it's just access to healthcare. Like the same standard of healthcare should be the most obvious minimum standard.
Larry?
As a 50-year resident of Orange County who escaped the desert, philosophical, moral, political desert that Orange County is, and entered the Garden of Eden in 2016 as a retiree, I was very impressed with the statistical story of good health in Marin County. Orange County is a very different place. And when Matt is talking about his team and what they stand for and burnout and everything else, I wonder if he knows of any comparisons of the Orange County model, which is a more conservative model, a less, I hesitate to use the word, but let's say socialistic. We have Social Security, so it's not entirely a toxic word, comparing health outcomes with the approach that Marin takes to health outcomes with the approach that Orange County takes. If you think you're frustrated by practicing in Marin in primary care, I just will mention in a brief sentence that as a nephrologist, a miracle happened in 1971 when a whole class of disease became covered universally. And we have an example in nephrology of everyone, including the undocumented, with end-stage renal disease who become eligible for dialysis. That has been a major miracle in healthcare, and I've been the beneficiary of not having to look at that corner of the chart, at least for end-stage renal disease.
Mm-hmm.
And when you talk about burnout, I finally burned out at age 86 in a wonderful system that we have, our Marin Community Clinic, over an issue of I wanted to see nephrology nurse practitioners used because nephrologists just aren't available because the socioeconomic situation in Marin. We're understaffed. Well, if a lower level person can do 75% of the work that a higher paid person, and the analogy is what you mentioned with psychiatric care or rehabilitation. You need, and your approach of looking at how you get more bang for the buck. Because unfortunately, in our materialistic society, with our genetic structure, materialism isn't going to disappear. So more bang for the buck is the formula that works. And I don't know, I just want to give you a pep talk from a veteran of a similar route and tell you we do live in the Garden of Eden.
Yeah. Thank you. That's great. Yeah. And maybe the fact that happened, that somewhere along the line, someone fought those fights to say, when someone needs dialysis, by definition, if they don't get it, they're not going to last long. And that we're going to appeal to a higher ethic of the dignity of that person, and their documentation status isn't going to. That was the right thing, right? So there's these glimmers of hope out there that, like, we're not maybe too far gone. And I just think we need to amplify that, because that was compelling, and probably came because it's such an obvious use case, right? But across the spectrum, the same could be true for management of hypertension, management of diabetes, across the spectrum. That just the only difference is sort of the length of time that it might take to affect that person's health and well-being. So I think that's part of our goal. And you mentioned Marin Community Clinics. Another asset we have, and maybe it's another thing for you all to know, is that we have in terms of like support and legislative stuff, is our safety net, like anything that can strengthen the safety net. So community clinics, those clinics that are dedicated to serving our lower income residents. We have such a great system. Those are the best. They are wonderful doctors. They're excellent doctors. They could be working almost anywhere, but they're choosing to serve that community. And they work really hard under really hard circumstances, and they need all the support we can offer them. And the gratitude. I spend a lot of time with those folks. I think it's one of the strongest relationships between public health and the safety net system, because they're really, when it comes to health equity, they're doing the work. So, and there, there's, I guess that's, there's sometimes legislation and opportunities to sort of advocate for more support for that piece of the healthcare system. And we'll just keep our eyes out for that stuff and dialogue when that comes up. Hopefully this was a helpful conversation. I've got to.
Yeah, I was going to say, you probably have to go. You're beyond what you
Yeah.
told us.
Yeah. That's
Okay,
great.
so thanks so much. I
Yeah.
really appreciate you coming.
Thank you so
Great
much
seeing
for
you
coming.
guys. Thanks. Oh, and get your bivalent booster.